and we have two interesting topics. One is on hypertension management and diabetes, Dr. Dinakaran sir, and next we have a talk on vitamin D replacement, how we do great by Dr. Velayathan. To coordinate and chair this session, we now request Dr. Dharmaraj sir, Senior Physician, Dean of Madurai Medical College and GRX, sir, please to the stage. And next to co-chair, may I request Dr. Virgin Jona Madam, Head of the Department and Senior Physician, Velamal Medical College, Madurai. And over to the chairperson.
Morning. First of all, thank overall organization for the opportunity. The first topics, how you manage hypertension diabetes. You know the speakers, there are such a well-known nephrologist. It's the first renal transplant in South Korea. The persons, my teacher, there's no need for the process. Well-known person in Madurai and surroundings.
Respected chairpersons and my dear members in the audience, friends and colleagues. I'm thankful to Dr. Kumaraveli and his team for inviting me to take part in this receptor meeting, which is being held continuously for more than 10 years now. I have taken part 2 years ago in this meeting. I am happy to take part today. The topic given to me is hypertension management in diabetes. You may think, what is there in hypertension management in diabetes? It is just like any other hypertension. We have to use antihypertensives. But in the context of diabetes, there are certain changes in approach and there are certain objectives which we have to fulfill in treating hypertension. It is not just controlling the numbers. As somebody remarked, hypertension therapy is not in numbers, especially in the presence of a metabolic disorder like diabetes. So we'll go into it. Diabetic kidney disease accounts for more than 40% of cases of CKD globally. It's one of the important contributors for chronic kidney disease. And for diabetes progressing to CKD, hypertension is a major risk factor for progression. Not only for CKD, but also for cardiovascular disease and mortality. So when we talk of hypertension management in diabetes, it needs meticulous management of hypertension. Crucial to slow down the progression of CKD and all its offshoots in all the vascular systems of the body. Why is this different from ordinary hypertension? The coexistence of diabetes and hypertension synergistically increases the risk for macro and microvascular complications. We all know macro and micro complications are part of diabetes, it's also part of hypertension. But when these two villains act in concert, they do it with extra vigor, and the results are too serious to control, especially if you allow things to drift a little too far. Unless you catch them early and treat them comfortably and correctly, you may not be able to stop the damage at a later date. So this combination will lead to coronary heart disease, peripheral artery disease, stroke, retinopathy, nephropathy, as well as left ventricular hypertrophy and congestive heart failure, compared to either diabetes mellitus or hypertension. So both can cause, but when they act together, they do more havoc. So this is the ADA statement in 2017. Hypertension is a strong initiating, comorbid and aggravating risk factor for diabetic nephropathy in all its stages. So what we have to understand is that treating hypertension in diabetes is not just for the control of hypertension, but has a pivotal role in slowing diabetic nephropathy, progressive CKD and CVS. That's the goal. It's not the number. Whether you reduce it to 130, 80 or 140, 90 is not the story. It's not the end of it. That's the beginning. You have to prevent diabetic nephropathy, which has got lots of sequelae, progressive CKD, worsening renal function, end-stage renal disease, high cardiovascular mortality in stage 3 stage of CKD, etc. Cardio and renal protection is the reality, is the need of the hour when we treat hypertension in diabetes. So that we have to remember in mind. Our aim treating hypertension is to reduce cardiac and renal morbidities and the cardiac and renal related mortalities. So in this, we are not relying on antihypertensives alone. The scenario has changed. The last decade has introduced wonder drugs that play a very important role in managing diabetes and also hypertension and vascular damage. Sodium glucose transport inhibitor, non-steroidal mineralocorticoid receptor antagonist. Unless we talk about this today, any talk on diabetes is not complete. So these new agents have found to improve cardiorenal outcomes, and they also have the modest BP lowering effect. That's why in this context, I thought it's better to include some words about these two drugs also and how they offer protection. Diabetes, what is the incidence of hypertension? In type 1, the incidence of hypertension is 5% at 10 years, 33% at 20 years, and 70% at 40 years. As the severity of nephropathy increases, CKD progresses from stage 1 to 3 like that, incidence of hypertension also goes up. That is more relevant in type 2, where 33% will have hypertension at onset of diabetes itself, 19% without any renal change, and 30% when they develop a renal change, they telltale evidence of renal involvement in the form of microalbuminuria, and 65% with macroalbuminuria, that means proteinuria more than 300 milligrams per gram of creatinine, and 75 to 80% will have hypertension when they reach stage 3, 4, 5 CKD. So, look at it in the reverse way. As hypertension incidence goes up, the severity of renal failure goes up. That's what this means. With mild degree of renal involvement, the incidence is low. With proteinuria, it goes up. With macroalbuminuria, that means established renal involvement. And with progressive CKD, stage 3 or 4, chronic kidney disease, hypertension goes up. Is it the cause or the effect? Both. They play a role in both causing this damage and also it gets worse because of the renal failure and falling eGFR. So we have to tackle both, protect the kidney, protect the heart, protect the vasculature, prevent retinopathy and prevent peripheral vascular disease, both macro and microvascular complications. Can we achieve that with blood pressure control? Yes. 32% reduction in diabetes deaths, 44% reduction in stroke, 37% reduction in microvascular complications with a reasonable control of blood pressure. This is again from BMJ and quoted in ADA. So, why should we talk differently about managing hypertension in diabetes? Is it different from other hypertensives? Yes. Diabetes reduces the efficacy of antihypertensive drugs, indicating that more aggressive BP lowering therapies are necessary for the treatment of mild or moderate hypertension in patients with diabetes. Why is it so? What are the factors in diabetes that contribute to this resistance to treatment of hypertension in a diabetic? Because there are certain common pathophysiological mechanisms in diabetes mellitus and hypertension, especially hypertension developing in diabetes mellitus has got a lot of other pathophysiological mechanisms which are not routinely controlled by the routine antihypertensive agents. What are they? Neurohormonal activation, neurohumoral activation. We are very much aware of the increased sympathetic nervous system activity, the RAS activity. These are more prominent, more common and more relevant in a diabetic who develops hypertension. And there is abnormal renal sodium handling and volume overload. This is part of diabetes, part of insulin resistance and part of the genetic background between diabetes and hypertension. Vascular remodeling takes place in diabetes. There is endothelial dysfunction, arterial stiffness, increased peripheral vascular resistance. Endothelial dysfunction, how do we identify that? The earliest evidence of endothelial dysfunction is the presence of protein leak above 30 milligrams per gram, which we previously used to call as microalbuminuria. What is this microalbuminuria? Microalbuminuria shows the susceptibility of the endothelium to a hemodynamic stress. It's a marker of endothelial damage. So there is endothelial damage in all the vasculature, but only hint that we get is from the renal microalbumin excretion. Then there are problems like oxidative stress and inflammation. The last one, inflammation, is the one that is gaining a lot of importance in correcting progressive CKD and CVD, because these inflammatory mediators that ultimately result in cardiac fibrosis, cardiac failure, renal fibrosis, and irreversible progressive CKD. So we'll just see how these are tackled in addition to the routine ways in which we control blood pressure. So this is the changing pathophysiology of diabetes and hypertension. In diabetes, there is insulin resistance, and when you use anti-diabetic agents, hyperglycemia is the hallmark of this insulin resistance. And the common pathophysiological mechanisms that are common to both diabetes and hypertension are these: inflammation, oxidative stress, the neurohormonal activation. I told you humoral activation, RAS activity, sodium and volume retention, increased sympathetic activity, vascular remodeling in the form of endothelial dysfunction, arterial stiffness, increased peripheral vascular resistance, etc. All these play a role or link diabetes with hypertension. So, do the drugs that we use for hypertension touch all these pathophysiological mechanisms? If they don't do it, how will we be able to solve the issue? That's what we have to see. So, we will discuss the approach to hypertension in diabetes under 3 therapeutic strategies. 1, as I said, the response of hypertension in a diabetic is poor, so up titrate your antihypertensive drugs. Use them to the maximum tolerated dose. That's the first mantra or the first hint. Improve diabetic control. Unless you have diabetes under control, unless you prevent the sodium retention, unless you prevent the volume overload, unless you prevent the ongoing vascular damage, endothelial damage, etc., excess endothelial activity, you may not be able to achieve good control of blood pressure. And then the targeting of the pathophysiological mechanisms that I enumerated in hypertension and diabetes, they are not directly targeted by our antihypertensive agents like calcium channel blockers or beta blockers or alpha blockers, etc. You have to think about them separately and use appropriate maneuvers or drugs to control these pathophysiological mechanisms. Then only the story will be complete. So let us start from the conventional way of treating hypertension, the lifestyle modification. Reduce salt intake, moderate exercise, keeping weight under check and reducing the alcohol. Physical exercise at least 30 minutes per day or 150 minutes per week. Body weight should be in the normal BMI. Reduce salt intake less than 5 grams of salt, common salt that we take. That is equivalent to 2 grams of sodium. Don't get confused with 2 and 5. 5 grams of salt equivalent to 2 grams of sodium. Reduce alcohol intake. So, just an outline about the different types of diabetes, the stages of CKD, and what should be the BP target. This is the outline, this is the beginning. So, if you have a type 1 diabetes, normal kidney function 140/80 and normal kidney function microalbuminuria 130/80. See the difference. Once albumin sets into the scenario of diabetes and hypertension, the target should be lower. Stage 4 to 5, you have to relax this. Keep BP at 140/90. And CKD stage 5, again 140/90. Aiming for lower BPs at stage 4 and 5 may be a little detrimental, and so this sort of a curve. Start with 140/90, albumin is there 130/80, CKD progresses, again go back to 140/80. Type 2 diabetes also follows a similar pattern of BP control. Just elaborate on that. In people with type 1 and urine albumin less than 30 milligrams per gram, that is in the stage where there is no albuminuria, BP in erect posture should be above or equal to 140/90. But once proteinuria sets in, the telltale evidence of endothelial damage in the kidney is identified. People with type 1 albumin creatinine ratio more than 30 milligrams per gram. That means they are in the microalbuminuria stage. RAS blockade should be started irrespective of BP. Even if your BP is 130/80, if there is microalbuminuria, RAS blockade is indicated. That's one exception for treating hypertension in diabetes. We are not treating hypertension here, we are treating the microalbumin. Target BP in younger adults should be less than 130/80. In aged people, it should be 140/90. Use ACA-ARB to the maximum tolerated dose. This is a word which I have to stress for the physicians and other treating doctors. We are a bit jittery about using these ARBs and ACEs. We are worried about the potassium, we are worried about the falling EGFR initially. They are not the actual indications for reducing the dose of ACE-ARB. Don't be perturbed by these small changes. Insist, persist with maximum tolerated dose. Type 2 diabetes, more or less the same. Proteinuria less than 30 milligram, BP 140/90. When the urine albumin creatinine ratio is more than 30 milligrams per gram, the target is 130/80. And how do we go about adding the drugs? I am not going much details into the individual class of antihypertensives using this, because I want to shift gears and concentrate on the newer concepts with relation to SGLT2 and MRAs. Just a slide about how an ARB will act in concert with other antidiabetic drugs, and then how blood pressure control in type 2 will bring about benefits. Myocardial infarction, any diabetes related endpoint, diabetes related death, microvascular endpoints, renal failure, stroke, heart failure, all are brought down considerably by blood pressure control in diabetes. This is one slide which stresses the importance of controlling hypertension optimally and with the maximum tolerated doses and with the permissible combination of drugs. We will try to achieve this. What are these combinations? You can use calcium channel blockers, beta blockers if there is an indication, alpha blockers if there is resistance to management with the conventional drugs. We will see that a bit later. So, our mainstay so far, what I have stressed, is the use of ACE and ARBs. They reduce the progression of kidney failure. They are not only antihypertensive, they are anti-proteinuric and they are anti-progressive CKD treatment. There is a 28% reduction in risk. The rate at which CKD progresses, the rate at which cardiac events happen, the rate at which vascular damage happens, all are to definitely 1/3 curtailed by using ACE-ARB, but use it to the maximum dose. So the greatest benefit with ACE-ARB is achieved when you combine good blood sugar control with BP control. So the intensive glucose therapy in this study, peridoctal and endopamide, you see this orange block shows major microvascular and all renal events are brought out. So you cannot be half-hearted in sugar control, BP control, go wholeheartedly in controlling both. And this another concept in treating hypertension in diabetes. The outcome in hypertension therapy will depend on the level of proteinuria reduction. That's what is brought about by this slide. If you have people with proteinuria more than 2.1 gram, 1 gram, and proteinuria less than 1 gram, two categories, for the same level of BP control, the person with reduced protein need will have a better outcome. 1.7 is the relative risk. The maximum benefit you see when you keep the BP between 130 to 139 systolic. The relative risk is even less than 1.7. So 2 points which I have stressed. Control diabetes effectively when treating hypertension. Control proteinuria effectively when treating hypertension. Then only we will get the maximum benefits. This is a slide which shows that half-hearted treatment with the ACE-ARBs, withdrawing them too early. When you give a maximum dose, a sub-maximal dose, or when you discontinue, in diabetes what happens? When you discontinue, the risk goes up. Patient expired when you discontinue ACE-ARB. The number is steeply rising. Don't be jittery, use them to the maximum tolerated dose, watch for the side effects, get a feedback and continue to use them to get maximum benefit. Additional pharmacotherapy, this is the usual algorithm, ACE-ARB, CCB, combine both, add diuretics, resistant hypertension, you can take other drugs. So we'll go to the last part, the cardiorenal effects of SGLT2 inhibition. Why should we talk of SGLT2 inhibition when we talk of blood pressure management? Because it has an effect on blood pressure through natriuresis, volume contraction, reducing arterial stiffness and improving endothelial dysfunction. And SGLT2 should be used after full dose of RAS blockade has been used to add this on. Possible mechanisms of blood pressure reduction, one is through the volume contraction, weight reduction, renal remodeling are the changes that are important are reduced intraglomerular pressure, reduces albuminuria, reduces hyperfiltration, reduces tubular inflammation injury. And this is what I started with. It's not enough if we control the number, the BP reading, but the tissue. What is the damage in the glomerulus? What is the damage in the vasculature? And what is the damage in the tubule? Unless you have a drug that will act on this, you will not get the full benefit of treating hypertension in diabetes. This is the other mechanism of action of SGLT2 inhibitors. The sodium hydrogen exchange channels present in the kidney, they facilitate excretion, retention of sodium and urate, and when we use SGLT2, NH3, E3 is blocked. So sodium is lost, urate levels do not go up. So what do we gain by combining SGLT2 with RAS? When we do it untreated, this is the rate at which people reach ESRD in about 5 years. With RAS inhibitor, we can go up to 10 years. When we add SGLT2, we can go up to 25 years. This is with regards to aldosterone. Aldosterone plays an important role in all vasculatures, lead to hypertension, heart failure and CKD. And when we block that, we get the benefit of preventing the organ damage. So a non-steroid MRA should be used for cardiovascular benefit in type 2 DM, GFR more than 25 ml, normal potassium that's less than 5, and albuminuria more than 30 milligrams per gram. That means they have established proteinuria, they have falling GFR, and they need cardioprotection, that we have to use it. So this is a summary slide. You see here that there are different steps by which we can prevent the progressive renal damage. SGLT2 inhibitors we have already elaborated. RAS blockade we have elaborated. Finerenone decreases inflammation, decreases fibrosis, decreases endothelial dysfunction and decreases tissue remodeling. Another pillar that is entering the scenario is the GLP-1 receptor agonist. For want of time, I will not touch upon that. Thank you.
Thank you, sir. Thank you for an elaborate talk on hypertension in diabetes. The floor is open for discussion.
Sir, what fluid can administration for diabetes and hypertension?
What?
Fluid.
Fluid. So diabetes and hypertension, amount of fluid administered will depend on one, severity of renal failure. When the renal failure starts entering the scenario, GFR starts falling, there will be fluid retention. Second factor is the heart failure, which again inevitably enters the scene after some time. Unless you have telltale evidence of fluid retention, unless the urine output per day is less than 1500 ml per day, there is no need for fluid restriction. But the point that we have to remember is the fluid restriction has to go hand in hand with salt restriction. The first step is salt restriction. So most of our patients are aware that they should not take salt if there is hypertension or progressive CKD, but they don't restrict fluid. That is the scenario where fluid becomes a toxin. They go for fluid retention and hyponatremia, which is a big risk in these people. They come with altered sensorium, even fits. Sodium is less than 125. It's going to be an emergency to be tackled. So, the fluid restriction and salt restriction should go hand in hand, and it should be relevant to the clinical situation.
Mr. case here in stage 3 of stage 4 CKD patient. How often should we monitor renal functions in production?
Stage 3 and stage 4 CKD. How often should we monitor the renal function?
Renal functions and protection.
See, in staging of CKD, stage 3 is a very important stage today. that is GFR between 30 and 59 ml per minute in stage 3. Because many events happen during this phase, the cardiac events start overtaking the renal disease at this stage. The stage 3 is now divided into two. Stage 3A, 45 to 59 ml GFR, and stage 3B, 30 to 44 ml GFR. This is a very vulnerable and very critical state of CKD. So, once we reach a stage of stage 3 ARP, that is a GFR less than 59 ml, in rough parlance for physicians, a creatinine value of more than 2.5 is the stage at which you are entering into stage 3. Because many labs do not do eGFR. And a person with 2.5 milligram creatinine, if he is 20 years old, weighing 45 kg, his GFR will be high. If the same person with 2.5 creatinine, if he is 60 years old and weighs 60 kg, the GFR will be low. Because based on his calculations. So roughly, the creatinine more than 2.5 denotes a very critical stage in CKD. Once somebody has reached that stage, initially when you are seeing him, you must do the parameters once a month. Especially when you are putting on ACE inhibitor or SGLT2 inhibitor, if GFR is more than 25 ml, you need to repeat the serum creatinine and potassium after 3 weeks. You have to watch whether there is a dip in creatinine, whether there is a rise in potassium. A dip in serum creatinine more than 1/3 of the previous value will mean that you have to moderate your approach. If your potassium goes above 5.5, you will have to be again very cautious about continuing these drugs. So we need to monitor once a month. Once you do that for 3 months and you have plateaued the creatinine and potassium, it's enough if you do it once in 2 or 3 months. But once somebody has crossed stage 3, initially at least they need once a month renal parameter, which should include estimated GFR, potassium compulsorily, sodium and other parameters, proteinuria, severity of proteinuria, all that has to be monitored.
Well, the new point which is very useful, sir. So, two doubts, sir. Once a diabetic becomes hypertensive, right from day one, we put him on the SGLT inhibitor, sir, along with for diabetes, along with anti-diabetes drugs.
Diabetes
By itself is we should put him on SGLT inhibitor right from day
No,
one.
I just repeat that question. If somebody with diabetes has developed hypertension, BP is more than 140/90 and also has proteinuria, that means more than 30 milligrams per gram of creatinine, that's microalbuminuria, you are justified, permitted and you can use SGLT inhibitors from that day onwards.
Right, sir. Then we were taking in the stage 3 kidney disease, we should target the BP at 140 and 90 and not less than that. Why should stage 3
Elderly and in stage 3-4, you have to monitor the rate at which the CKD progresses. If you can go below 140/90 and see that the creatinine doesn't rise, you are justified. But this is a general precaution to keep it at 140/90.
Then, as per the guidelines, fludarabine can be given only after maximum tolerant doses of ARBs or ACE inhibitors.
Which one?
Fludarabine.
Finrinol, yes.
But do you have to put the maximum dose of telmisartan or then only you should go for with 40?
Yeah, both SGLT2 inhibitors and Finrinol are add-on drugs after RAS blockade drugs used to the maximum tolerated dose. This is a dictum. You use SGLT inhibitors if you feel that there is some need for diabetic control, cardiorenal protection in addition to RAS blockade. I showed one slide. The RAS blockade alone, you can prolong it to about 10 years, reaching end stage. Adding SGLT2 prolongs it by another 15 years. That's a benefit. You cannot forego that. Finrinol is used in type 2 diabetics, eGFR more than 25 ml per minute. If there is some telltale evidence of heart failure, then it is indicated. Again, it should be used after maximum tolerated dose of RAS blockade.
Thanks.
Then what way non-steroidal corticosteroid receptors are better than the steroid non-steroidal?
Definitely. There is a lot of evidence to show that non-steroid MRAs are better, especially for preventing cardiac and renal fibrosis. They may not be better than steroid MRAs for diuresis, for heart failure, improving diuresis, etc., or controlling BP. their spironolactone, eplerenone still have the same. But when you want to prevent cardiac fibrosis, adrenal fibrosis, the drug of choice is finerenone, but something else is evolving. Aldosterone synthase inhibitors are coming. They are more specific for this purpose. There are a lot of trials going on, and once they enter the scenario, they may even take over finerenone. And as far as the SGLT2 inhibitors and other drugs are concerned, the twin cretins, the tirzepatide, that's again coming into vogue, which is reducing the weight drastically, has better blood sugar control, and has better effect on volume control. So these are the two things that we are awaiting. Tirzepatide has already been approved by FDA. Aldosterone synthase inhibitors are in the pipeline.
Sir, good morning, sir. Thanks for your relaxation. Only one question. 10-year-old diabetic with good control, normotensive, not even no proteinuria. Is there any prophylactic value of AC inhibitor to prevent the proteinuria? Postpone the onset of CKD because early onset institution of AC inhibitor. Can we postpone the proteinuria? Or is there any role of prophylactic AC inhibitors?
If there is no microalbuminuria, if the BP is less than 130/80, even if the diabetic duration is 10 years, there is no role for RAS blockage.
Thank you.
Thank you very much, sir. This was the need of the hour. As we know, diabetes is skyrocketing, CKD is equally skyrocketing. It's going to be a huge public health burden. And thank you very much for an excellent, clear presentation. Thank you. Definitely. We really were looking forward for that. Dr. Kumaravil attended your wonderful lectures. We were really amazed at how much information we received from that. I would like Dr. Professor Dharmaraj to felicitate our speaker.
I express my profuse gratitude for giving me this opportunity and for the very receptive audience and the response. Thank you.